Hello, we're going to go over this review article from the New England Journal of Medicine from May 25th, 2017, and it's about acute myocardial infarctions. Actually, it's really about the in-hospital management, the treatment of myocardial infarctions. And this one really first starts out by distinguishing between 6 different types. The first one is due to a blocked vessel. The second one is due to a supply-demand mismatch, meaning there's not enough blood getting here because the heart just needs more. The third one is sudden death, so we'll never really get to see these ones. The fourth ones are iatrogenic, so caused either during stent placement or angioplasty or during stent thrombosis. And the fifth one is a complication or clotting of a graft. And in this one, we're going to talk really mostly about type 1. And let's start off with some epidemiology. There's 550,000 new MIs and 200,000 recurrent MIs, which have a death rate of about 4 to 5% death or hospitalization per year. Now, contrast this with the rest of the world, where it could be as high as 80% in the poorer countries. And what happens is you're going to have a lipid-laden plaque that forms, and either it erodes or it actually ruptures. And once it ruptures, you get platelets forming here, and you get the whole coagulation cascade happening. And then you get this, what's called a thrombogenic tear. And this could either fully block or partially block this blood vessel, leading to either a STEMI or a non-STEMI. So here's a timeline of what should happen for treatment for a patient who presents with a myocardial infarction. And it starts, of course, with the patient who's having symptoms, maybe some ischemic chest discomfort or dyspnea or unexplained weakness. And probably the first thing that they're going to do is call an ambulance. So the ambulance oftentimes will have the ability to do an EKG within the ambulance and transmit that to the hospitals. But that will often save 15 minutes or so of time in the patient's care, but can lead to some false positives, meaning that we call in the cath lab team and when it turns out not to be a myocardial infarction. There has been a bunch of studies that looked at giving certain meds in the ambulance, like ticagrelor, or even doing cooling in the EMS, therapeutic hypothermia, or targeted temperature management. And they've really not been shown to save any lives. Okay, so let's say now that the ambulance gets to the hospital, and now the clock starts ticking, and that's 0 minutes. And in the first 10 minutes, we got to do a couple of different things. First of all, we got to get an EKG and send the troponin, reading the EKG within 10 minutes, looking for signs of STEMI. And for those that you're worried that this might actually be acute coronary syndrome, you're going to have to initiate some emergency room care, and it starts with maybe oxygen. That's what we used to give that to everybody. But now, studies are saying that maybe only give it if there's decreased SATs or the patient's in respiratory distress, and it may not be helpful, and sometimes maybe it's even harmful to give oxygen when it's not necessary. Nitroglycerin is often given as well. Nitroglycerin tablets, sublingual, ×3, and if that doesn't work, then you can switch to IV till you relieve the pain. I find that there really is no use for the nitro paste because you really have no idea how much nitroglycerin is getting to the patient, and so I don't know that that helps any. Beta blockers have been shown to help as well, but they have to be given within the first 24 hours, and oral is okay. You can give IV if you want, right, if the patient is extraordinarily hypertensive and you need to control their blood pressure. But of course, the converse of that is the worry as well, that if the patient is in cardiogenic shock, you're not going to give it. But if they're going to develop cardiogenic shock, you're going to wish that you hadn't given it. And so talk to the cardiologist to decide when you want to give this. You have 24 hours to give it, and so maybe wait a while before giving to make sure that they don't develop shock. ACE inhibitors and statins as well have to be given within the first 24 hours and have been shown to help outcomes. Again, talk to your cardiology team and decide when you want to give those. Okay, now we have to decide what we want to do. And by looking at the patient, we're gonna decide whether we think they're having a STEMI or basically this is risk stratification. Okay, if they have an ST elevation on their EKG, then they have a STEMI. They have an ST elevation MI, and they need to go to the cath lab. You're going to call the cath team, and they're going to do that. If they have obvious non-ischemic pain, maybe they got hit in the chest or something, some other reason, then you can treat that accordingly. It's those in the middle that you have to worry about. Now you have to try to risk stratify these patients to see if they have possible ACS. And so if you have, we'll have drawn a troponin and done an EKG. Now I'm assuming it's not a STEMI because otherwise we wouldn't fall in this category. So with that first troponin, if it's positive with a normal EKG, we call that a non-STEMI, and we're going to treat that accordingly. If it's a normal troponin, then we have to do some more risk stratification, and that includes repeating the troponin and repeating the EKG. If both are normal, you might want to do some provocative testing. If one of them comes back positive, like you get a STEMI on the repeat EKG, they need to go to the cath lab. Or if the troponin is positive, then you got to treat this as a non-STEMI. And so at Rush, we do 4 hours in between our troponins. But there are these highly sensitive troponins that are coming out that may be useful in as much as 1 or 2 hours. And what is a positive troponin? Well, with these highly sensitive ones, we've got to figure that out. But it's usually going to be something that is above the 99th percentile to be treated as positive, because there are lots of false positives as well. Other things can cause a positive troponin in these highly sensitive ones. Now, we used to order these tests like CKMB and myoglobin, but there's really no need to order those anymore. And so another thing we can look for is a rising trend, a rising level, which could speak towards potential cardiac cause. So now we're going to talk about the treatment of STEMI that extends past the emergency room, but it's still good for us to know. And so you're really going to have, maybe one of 3 different possibilities here, right? You could have a plaque that is flow limiting. Look, there's only a very narrow lumen here. You could have a clot here, but there's still space here. And so this is a acute clot with a chronic plaque, but it's not fully occluding. And this one, there's a clot, but it's also fully occluding. And so what happens? In this one, the flow-limiting one, you tend to get ST depressions. With the plaque that has some space, you're also going to get ST depressions. If you got full occlusion here and you actually got infarction of cardiac muscle, that's when you get our ST elevations, right? And so we're going to send the troponins as well. And so with our ST depression ones, the troponin's either going to be normal or it's going to be positive. If it is positive, then we're going to call this a non-STEMI because we did not have the ST elevation, so it's called a non-ST elevation MI. And we're going to have that with a positive troponin. And what do you do in that case? Well, you're going to need to risk stratify the patient to decide whether they need to go to the cath lab or they get medical management, medical treatment. And one way that you can do this risk stratification is, you got to ask some questions. You got to ask, is this possible ACS? And if so, what is the risk of an adverse outcome? And it's the presenting features more so than the risk factors that are important. And there's two scores that you can use, the TIMI and the GRACE score. And there are online calculators you can look at in order to calculate these things. But here are some of the things that are in it. So you can see there is some overlap between them, but like the TIMI has weight and time to treatment, as well as some of these risk factors in it as well, where the GRACE one has creatinine, elevated troponin, or they had a cardiac arrest in here. So they're fairly similar, but these are just ways to risk stratify your patient. So depending on whether the patient is higher risk or low risk, you can make this decision. So obviously lower risks, you could tend to do some of this medical treatment. And so, and sometimes they also in the article mentioned women are going to get this, tend to go down this path for some reason. Now the higher risk patients, you can decide if you need to do a cath. The higher the risk, the more likely you're going to do an immediate cath. For the medium risks, we're going to do early, whereas the ones that are lower risk, you can do elective cath. Now, patient preference also plays a role in here. If they don't want to have a cath, you might want to go down this route. Now, those who get caths or don't get caths, they're going to get dual antiplatelet therapy as well as anticoagulant therapy. And I wrote here what they are. So the dual antiplatelet therapy is going to be aspirin and one of these P2Y12 inhibitors. And I've listed them here: clopidogrel, prasugrel, and ticagrelor. I have no idea how you say that one. And then you got your anticoagulants, which are the various heparins and bivalirudin. All right, and if you do the medical route, you can see we took bivalirudin off of here. Now let's look at the ones who had the STEMIs, right? And so these are the ones who had an ST elevation. So since they had infarcted muscle, they're probably going to have a positive troponin as well. So what are you going to do in those cases? We used to give TPA for this, but TPA really is not worth doing because, it has increased risk of reinfarction, death, and bleeding. So the cath lab does tend to be safer. And you want to do that if you have an in-house cath lab within 90 minutes. Now, if you don't have an in-house cath lab, you might have to transfer the patient, and you'd like to do that within 120 minutes. If not, then you might give a dose of TPA. During the cath lab, a stent might be placed, and they are often using these drug-eluting stents. And the one that they mentioned in here is the cobalt chromium everolimus stent, which tends to have good outcomes. And again, When they're done, they're going to get their dual antiplatelet therapy as well as their anticoagulant therapy. And then everyone afterwards gets medical management, which means a daily aspirin and some sort of P2Y12 inhibitor based on whatever kind of treatment that they had. Now, a few other things that were mentioned was during the angiogram, what do you do about non-culprit stenoses? So you find one that's causing the problem, that's causing the MI, but there's maybe another blockage here. And they're still studying that, and it could be open now or it could be opened at a different time electively. They also talked about what about aspirating the clot, manual thrombose aspiration during PCI? Is there an increased risk of stroke? And they said no, there's not. And the other thing they looked at is what about access? Where should you get the access, femoral or radial? And radial has actually been shown to have decreased bleeding, decreased death. It only took about 2 minutes longer. It did require more training. Which this was kind of a surprise to me because this artery is so much smaller than the femoral artery. So I thought, it must be harder to do, but apparently not so. Okay, we're almost done. We're going to talk about the treatment of non-STEMIs as well. We talked already that you can either do an invasive strategy or an ischemia-guided strategy, which is really medical treatment, and if you have to do an angiogram, if they have more pain. And this is for the lower risk patients, and you could do an invasive strategy, meaning an angiogram in higher risk patients. And we already talked about how we're going to deal with those non-culprit stenoses. You can do them now or you can do them later. We are not going to give TPA in these patients who have non-STEMIs. They talked a little bit about the antiplatelet drugs. Aspirin is one. We used to use these G2B, 3B inhibitors. They're older medications, so we don't use them as much as these P2Y12 ones, but you can get it IV and get it in faster if necessary. Now, there are different characteristics of these drugs. I don't know that you have to know that. Like clopidogrel can be given with lytics. Both clopidogrel and ticagrelor are given with the non-STEMIs. Prasugrel and ticagrelor work better with the cath lab. And clopidogrel is actually in an inactive form and needs to be activated by this enzyme, the CYP2C19. And some people don't have that enzyme, so those people need to get this ticagrelor. Okay. And we should, mention heparin again. There's unfractionated heparin, and then there's the low molecular weight heparins and these other anticoagulants. And they, how do they work? They work by binding antithrombin 3 and keeping it from inactivating factor 10A and thrombin, so it causes you to not clot. Enoxaparin is more effective than this unfractionated heparin, but this has the ability that you can turn it off if you need to. Bivalirudin has decreased bleeding but increased ischemic events, and it actually comes from synthetic leech spit, which I thought was kind of strange. And fondaparinol is really not good for a PCI. And so that's it. A quick summary of this article, Acute Myocardial Infarction, from the New England Journal, May 25th, 2017. Thank you for watching. Bye-bye.